And I'd also like to introduce our next speaker, who we were lucky to secure for this meeting. He's the world's expert in malaria in pregnancy. He is currently at PATH, which is the Program for Appropriate Technology in Health. That is based in Seattle, but he also lives in Atlanta. Try that one. He's adjunct faculty at Emory and the University of Washington, and you think it's difficult to have offices in the clinic and the hospital. He's trained in family practice and also did a preventative medicine residency at the Centers for Disease Control, where he was for 21 years, 5 of which he spent in Malawi. He's been an advisor to numerous organizations, including the World Health Organization, UNICEF, the World Bank, and now the Foundation for Women and Girls with Blood Disorders. Thank you, Dr. Seketi.
Thanks very much for the kind invitation and for the organizers inviting me to talk. Also, thanks for putting me up on the podium following sickle cell disease. So, as most of you know, and from early on in your training, you realize that this is the one example where an infectious disease has driven a chronic problem across the entire globe. So I'll take full responsibility for that, for the malaria community. The good news is that sickle cell trait is actually enormously protective against malaria in the environment where you have no treatment for malaria. Luckily, we're not at that place anymore. Unfortunately, having driven the population prevalence of sickle cell trait and thus disease, it won't go away because we have good treatment for malaria. Not just centuries, but many, many millennia. So we will take no solace in the notion that we caused the problem, but we actually don't have any solution for it. So let me talk a little bit about malaria in pregnancy for you. So first of all, I'd like to thank a couple of people. There's a Malaria in Pregnancy Consortium that's been working across this. Jenny Hill, Faiko Terkaila, and Jane Webster helped a lot with some of the materials for this. So our objectives are to understand the global burden of malaria and why it's devastating to pregnant women and neonates, and then to examine current strategies to prevent malaria in pregnancy and align the most feasible strategies by location and patient population. I'd like to point out that implementing the strategies to control malaria during pregnancy do require bridging multiple disciplines. This is actually a relatively first that had an opportunity to talk to the hematology community about this. And there's sort of the malaria world, the reproductive health world, and the hematologists who are involved. And for those of us who sit in one camp, it's hard to know exactly where the others are and what they're doing about it. And so I really appreciate this opportunity. So this is the organization of my talk. I'm going to present the notion that it's a big problem. It has some very interesting biology. I wouldn't have spent an entire career in this if it hadn't had such an interesting biology. It is fully preventable and treatable at this point in time. And global recommendations have even recently in this past year been clarified to try to make the interventions and the prevention approach that much clearer and therefore that much more acceptable. Many countries do have a coherent policy, and implementation of that policy, however, has been limited. And the ownership of the problem and the programs has been a challenge, and that's hopefully fixable. So let me talk about the problem. So you heard about the burden of anemia, and I'd like to point out that I've got here Plasmodium falciparum malaria and Plasmodium vivax malaria distribution and risk in pregnant women. Of particular note, falciparum and all of that anemia that Nick showed you about in the first talk is really dominant in sub-Saharan Africa. And Plasmodium vivax is not there, and you know that reason. It has to do with the Duffy antigen on the surface of the red blood cell, and the Plasmodium vivax needs that, and much of Africa does not have that. So that's an enormous difference here. Having said that, vivax in Asia is common, and there are a lot of people in Asia, and a lot of pregnancies in Asia. And to be honest, while there's a large population in sub-Saharan Africa, it pales in terms of numbers of pregnancy compared to that which is happening in Asia and Southeast Asia. So this notes about 85 million cases of Plasmodium falciparum around the globe and 92 million of Plasmodium vivax. But it's not actually the sum of that. The sum has to do with the fact that many pregnant women are actually at risk of both. So the overall risk is that about 125 million pregnant women live in malarious areas and are at risk each year, and that 32 million of those are in Africa, and the risk in Africa is categorically different than the risk elsewhere. So on average, about 26% of pregnant women in sub-Saharan Africa have shown parasite infection during pregnancy during this past decade. In Asia, it's typically less than 10%. It's oftentimes less than 1%. Then you have to think about, well, what is the contribution of that burden of infection? And our understanding at this point is that the estimates sit that around 15% of maternal anemia in these malaria endemic areas is attributable to falciparum malaria or vivax malaria. That it contributes to 8 to 14% of low birth weight, and that's about 30% of the preventable low birth weight. And then from that, it contributes to somewhere in the range of 3 to 8% of infant death, most of that occurring early on. Let me move to the biology. So you can't have a malaria person stand up in front of you without showing you this wonderful life cycle. So this infectious female mosquito, so malaria people love to note that this is a talk about women and girls, and these are all women. And the older they are, the worse they are. So they inject the form of the parasite that goes directly to the liver. And that lasts in the bloodstream maybe up to 30 minutes, but not detectable at all. Goes to the liver, and inside the liver, it replicates. And so one parasite may move on to about 50,000 parasites in that liver cell. They break out of the liver cell, and that stage of the parasite goes to infect a red blood cell. That reproduces in the red blood cell and essentially is a 10-fold increase of parasites per infected red cell. So one red cell produces 10 more parasites. And those break out, and they go find new red blood cells. So it doesn't take very long when you've got a 10-fold increase every cycle to get many, many red blood cells infected. And then finally, some of those parasites go on to form a sexual stage of the parasite. That's a male and female gametocyte. And this unsuspecting mosquito comes along. She's also female. And she picks those up, and inside her gut, the male and female gametocyte get together and form a zygote. And that goes into the gut wall and burrows through the gut wall in what we call an oocyst. That's that green thing there. So that's now inside the body of the mosquito. And it migrates, it breaks out of that form and migrates into the salivary gland of the mosquito and is ready to be injected into the next individual. That whole process takes at least 2 weeks. if not 3. So it's not a quick thing, and unfortunately, this phase of the red blood cell cycle actually becomes a chronic disease. And there are 2 things that are going on there. One is that there is a very specific breakdown of red blood cells. There is a marking of other red cells that are not themselves infected, but that are going to be picked off by the spleen because they're just not normal. And then thirdly, there is a direct effect on the bone marrow and new red cell production. So this becomes a chronic disease, and pregnant women are not in good shape for it. So just what this looks like on a thin blood smear, you see the red arrows showing the little parasites. Those are the ones where the red cell's infected, and then that big banana-shaped one is the gametocyte that's picked up by the mosquito. So then on the pregnancy side, the fascinating biology here is that uterus and the woman's blood, indicated in red here, is pooled blood. So these are these arterioles feeding from the uterus, feeding that placental area, produce a pooled blood supply that's running at about 5 millimeters of mercury instead of the 120/80 that you might want to move blood through. So it's just sitting there. And it's then bathing the fetal supply over here, which is going to the baby. And that's all because that baby needs lots of oxygen and lots of glucose, and it takes a while for that to diffuse across. Now you put parasites in this space, and you have them chewing up oxygen and glucose. Instead of it going to the baby, you start running into trouble. So what happens? Parasites accumulate, they replicate in the placenta. There are higher densities and more mature stages because at a low pressure system, you don't even have to adhere to the surface. You've got low pressure and you've got a relatively non-distensible red cell, and they don't exit very easily, and so they end up being pooled there. The other thing they do is they call in monocytes and macrophages, and that whole process interferes with oxygen and nutrient transport. So this is essentially that same picture I just showed you a diagram of, where they're in the maternal space, this area here, we've got lots of infected red blood cells, and this shows you a macrophage that has been picking off those dead red cells and the hematin from the parasite. So let me just show you a couple of pictures to drive this home. This is a thick smear from a peripheral blood sample from a woman's finger stick at the time of delivery. So what you're looking at is you're looking at white cells, and all of those little dots are parasites. We've broken down the red blood cell membrane on a thick smear, and we're just showing you this mass of parasites. So that's her peripheral blood. And that's what her placenta blood looks like. So these are later stage parasites, and you can see the development of that. And then we go to the cord blood, and we're able to find a parasite. But that's just to show you how good that filter is, that almost nothing is moving across. And remember that that parasite's in a maternal red cell, and the fetus is actually going to pick that off anyway. So the fetus in this situation is not actually at risk of, and yes, there is congenital malaria infection, but for the most part, and particularly in sub-Saharan Africa, this is not a common phenomenon. I'll show you one more. This is, again, mother's finger stick blood smear at the time of delivery. She's got a few parasites. This is her placenta. She's got a huge monocyte infiltrate and a lot of macrophages, and they're chewing up, and those are dead parasites. So again, a huge amount of oxygen and glucose need for this whole process to go forth. And then lastly, the cord blood for this fetus yes, we can find the odd parasite, but again, it's an incredible filtration system. So then let me move to the notion, I'm still in biology here. This depends on transmission intensity, and it depends on the pregnancy number. So first, the woman comes in with cumulative immunity that she's acquired over a lifetime. And in sub-Saharan Africa, that can be substantial. And it's not gender specific. That is, she's liable to have the same amount of immunity as her age-matched male in the population. But there is also pregnancy-specific immunity that is garnered, because if she had a previous pregnancy that was exposed to malaria, she actually now has a memory system that carries on to the next pregnancy. It was acquired with that previous exposure, and then it's protective, triggered after that first infection. So in high transmission Africa, over on the left side, the population tends to have a high degree of acquired immunity over a lifetime of exposure. They themselves are asymptomatic when infected, so the mother doesn't present with illness. She does get anemic, and there is a little bit of morbidity during pregnancy, but most of the issue is low birth weight and the risk of infant mortality associated with low birth weight, which is the driving force in these populations. So on the right-hand side is a low transmission setting, Asia and the Americas. There is relatively little acquired immunity. The pregnant woman, when infected with malaria, is likely to get quite sick. She could go on to severe disease. She could go on to die, and before she dies, she will abort, because that's the source of her problem, is the ongoing infection in her placenta. So just to make sure that you don't think that low birth weight is just a small issue, obviously the baby on the left here has a much reduced chance of survival, and you put that in a low resource setting, and that newborn will be in trouble. So let me move on to the notion of treating and preventing this. There are essentially three interventions. One is that we prevent that mosquito bite to begin with, using insecticide-treated nets or indoor residual spraying in settings where that's used. That we provide prevention with intermittent treatment, intermittent preventive treatment, or IPTP, labeled with a P for pregnancy, with an effective and safe antimalarial. And then the third issue is case management, so for the woman who gets sick, to diagnose and treat her properly. We seem to be stuck here. There we go. So this has been the concept of how to approach this. And what this graph is from conception on the left to birth on the right. And we're plotting in this dashed white line the fetal weight velocity. So that's the speed at which it's gaining weight, not just overall growth, but that speed. And what happens is, as you know, there's organogenesis in the first half of pregnancy, and then the baby gains weight once all those organs are set and ready to go. And towards the time of delivery, actually the speed of growth starts to fall off, and the baby's weight stabilizes in the last month of pregnancy. To provide the intervention, it's great to own and use insecticide-treated nets even before you got pregnant, because, to be honest, much of the infection is already existing in the mother when she gets pregnant and is transferred to her placenta that way, rather than just being acquired once she's pregnant. So owning and using before and throughout and beyond for the infant is really quite critical. And then we've invoked the notion of using a safe drug, sulfadoxine pyrimethamine, been used widely in pregnant women. There are some side effects in terms of Stevens-Johnson's. That's rare and has been able to be managed quite quite well, and so we don't see it very much. When it does occur, it's managed well. But to give it repeatedly during that time when fetal growth is zooming, and giving it up to 4, 5, 6 times is certainly possible. So insecticide-treated nets, about full ownership and daily use. It's been shown in randomized control trials to really reduce the frequency of infection, maternal anemia, and low birth weight in infants. So it does all that we need it to do. And like I mentioned, it's prior to pregnancy, during pregnancy, and after pregnancy. It's nice to have both mother and the newborn under the net. Intermittent preventive treatment. This is a full course of a long-acting anti-malarial given regularly at intermittent points, typically at each scheduled antenatal visit in the 2nd and 3rd trimester of pregnancy. It's given approximately a month apart so that you're not overloading. You don't need it more frequently than that. And it's given presumptively as directly observed therapy when you can pull that off. And sulfadoxine pyrimethamine, because it's single dose, can be done that way. And essentially, it treats any existing infection as well as providing that prevention during that following 28 days or so. So global recommendations. So in 2010, the WHO treatment guidelines for this would be the case management of symptomatic women who need to be treated was updated, and so there's clear recommendations for artemisinin combination therapy in 2nd or 3rd trimester for sick women, and quinine in 1st trimester, although the data is increasingly coming in that ACTs are probably good in 1st trimester as well. And then secondly, there's prevention guidelines from WHO that were just updated in April of last year and then revised in January of 2014. This is the WHO policy for implementation of intermittent preventive treatment, malaria in pregnancy with sulfadoxine pyrimethamine. So how are the countries doing? So this is sub-Saharan Africa, which is obviously the focus of this discussion. And these are the years at which a policy was adopted. So the lighter the color, the earlier in time the policy was developed. So it began in Malawi, in Kenya, and Uganda. And last to adopt was Central African Republic. And then how are we doing in terms of implementing this? Well, that's a little sketchier. So this is coverage of intermittent preventive treatment during pregnancy as of 2010. And the darker the color, the better the coverage. And so there are essentially maybe 3 places that are doing pretty well. There's Senegal, there's Zambia, Tanzania, and Malawi, and Ghana is not doing badly. Having said that, much of the rest of the continent is such that just over 20% have received at least 2 doses during their pregnancy. Thus, 80% didn't. And that's against the fact that at least 75% of women in these countries, on average, are attending at least 2 times. But we're not getting the 2 doses to them. And there are only 2 countries that have gotten over 60% coverage, and that's Zambia and Senegal. So this is a nice graphic to show you how we've improved, though, over time from 2003 to 2014 in terms of our coverage. And I think you'll be pleased to note that that's a nice line going up. But that's 8 million pregnant women in sub-Saharan Africa, and that's because I set the scale that way, but that's not the number of pregnant women at risk in sub-Saharan Africa. So if we put the 35 million there, that same graphic doesn't look quite so good. So instead of seeing a nice uptick, that uptick is really working against a big problem. And this is how we're doing against ITN use in pregnant women. It's better. In some places, it's up to 40%, but it's still got a long way to go. So to summarize, this is a big problem. It's affecting a lot of people. It's huge in sub-Saharan Africa, but it's not non-existent, particularly in Asia and Southeast Asia, and some parts of the Americas. Hopefully, you've been interested in the biology. It is preventable and treatable. We're doing reasonably well in terms of clear guidance. There's still a long way to go in uptake. And the notion of who owns this has always been a problem. So anybody in the audience who's willing to take a little bit of ownership, we'd be welcoming that. And finally, there was a report this past year describing much of this in detail from the Rollback Malaria Partnership called The Contribution of Malaria Control to Maternal and Newborn Health. And that's available should you want it. Thanks very much. So now it's time for those wonderful questions. And the first one being, how many pregnant women worldwide are at risk of malaria infection in 2014? And there's A, B, C, or D. And you can... So we did pretty well. So definitely some learning going on. So what are the main strategies to combat malaria during pregnancy? Is it case management? Is it vector control prevention? Is it use of sulfadoxine pyrimethamine as intermittent preventive treatment? Or all of the above? Well done. And the current use of malaria interventions during pregnancy in African women is high at more than 60%, moderate in the 30 to 50%, low with 20 to 25%, or very low with less than 5%. Well done. And then finally, the situation for global and national policies for malaria prevention in pregnancy is best characterized as there's an incomplete global policy for malaria prevention and treatment, but it's hoped to be better. There's a comprehensive global policy that addresses all aspects of prevention and treatment, with particular emphasis on the situation in Africa. And most countries have adopted some or all of this guidance. C, there's a comprehensive global policy, but few countries have adopted the policy and guidance. And D, there's a comprehensive global policy for Plasmodium vivax, but not for Plasmodium falciparum malaria. So we split. Thank you very much.
I received a text from the National Heart, Lung, and Blood Institute. There is some interest among hematologists. Oops, lost it. There is some interest among hematologists there with respect to malaria, and they wanted this audience to know that there's an RFA out on vascular dysfunction in the pathogenesis of severe malaria, and they would like everyone here to know that they are invited to submit an application.
Since you work with PATH, I was interested in hearing some updates about malaria vaccine trials and how quickly you think we might see this being implemented to scale.
So the quick update on that, and happy to make have longer conversations should that be of interest. So there is one vaccine that has gone through phase 3 trials, is now being put forward for licensure. This is known as the RTSS vaccine. It's not specific to pregnancy by any means. It's oriented towards young children. It has imperfect but not inconsequential efficacy in terms of reducing disease, severe disease, hospitalizations, and visits for acute illness. And that reduction is somewhere in the middle range, that is 40 to 50% kinds of reduction. So there will be a lot of concern about putting forward a vaccine that is not really great, because people will get the vaccine and will still get infected and still get sick. Having said that, it's hugely beneficial to substantial populations, and so that will be the discussion. This will go for licensure this coming year, and there will probably be a lot of activity in terms of communication about it with WHO and other organizations, Gavi and the immunization community. Beyond that, there is a fair amount of work going on transmission blocking vaccines. And these are oriented towards stopping that side of that sort of left side of that life cycle where the parasite's being picked up by mosquitoes and moved to the next individual, and seeing if we can stop that. So.
Sorry, just as a quick question. We know that as time has been going on, many of the drugs have been developing resistance. What's been happening with the combination that's being used for pregnancy and using it intermittently?
So that's an interesting story. So what happened was that there is plenty of resistance to sulfadoxine pyrimethamine. The trials to date that continue to go on to look at the efficacy and whether or not it's doing what we need it to do suggest that even when children fail that drug, that pregnant women seem to do pretty well on it still. So that's the good news. That won't last forever. Maybe the other good piece of news is that we moved the primary therapy for malaria, particularly in children, to artemisinin combination therapies and away from SP, so that there is much less pressure on the parasite from sulfadoxine pyrimethamine when it's only used during pregnancy. So it's really being saved right now for pregnant women. So maybe that will keep it a little bit while longer. And then finally, there are some looks at alternative drugs for this purpose, and those are studies that are underway and ongoing.